OBGYN Resident Audio Lecture Transcript. Episode 3, Bile Acids and the Fetal Death Problem. This episode is based on Gabby's Hepatic Disease chapter, Gabby's Maternal Physiology chapter, the Israeli ICP position paper, the Ovadia 2019 Individual Participant Data Meta-Analysis, and the SMFM consult. Let us begin with the deepest idea in ICP. The mother's symptom is itching. The fetal risk signal is bile acids. Those two are related, but they are not the same. A patient can be intensely symptomatic and still not be in the highest fetal risk group. Another patient can have less dramatic itching, but very high bile acids. The resident who manages ICP by the loudness of the itch will make mistakes. The resident who manages it by the biology of bile acid exposure will reason correctly. So let us build the biology. Normal pregnancy already pushes the hepatobiliary system toward cholestasis. Estrogen rises, progesterone rises, gallbladder emptying slows, bile becomes more lithogenic. Hepatic transport has to function in a hormonal environment that is different from the non-pregnant state. Most pregnant patients tolerate that. ICP appears when the normal pregnancy stress meets susceptibility. Part of the susceptibility is hormonal. Estrogen has cholestatic effects. Gabby also emphasizes abnormal progesterone metabolism, especially sulfated progesterone metabolites, as a proposed contributor. This is one reason ICP tends to appear later, when placental hormone burden is greater.
Part of the susceptibility is genetic. Familial clustering and population variation are real. Gabby mentions multi-drug resistance type 3, MDR3, which encodes a canalicular phospholipid pump. If canalicular transport is vulnerable, bile composition and bile flow become less stable under pregnancy stress. Part of the susceptibility is clinical background. Prior ICP, family history, multifetal gestation, IVF pregnancy, age over 35, and hepatobiliary disease all increase suspicion. Multifetal gestation is especially intuitive. More placental mass means more hormonal load. A system already near its transport limit is pushed harder. Now, what is the final common pathway? Bile acids are not excreted normally from hepatocytes into bile. They accumulate in maternal serum. They accumulate in tissues. In the skin, this contributes to pruritus. In the fetal environment, they create risk. Now, we have to be precise. ICP fetal death is not best understood as classic chronic placental insufficiency. In fetal growth restriction from placental disease, we often think of a gradual process. Placental resistance rises, growth slows, fluid may fall, Dopplers may deteriorate. Fetal testing may show a trajectory. ICP is different. SMFM notes that stillbirths have been reported within days of a reactive non-stress test. The mechanism is thought to be more sudden. Fetal deaths in ICP are not typically preceded by fetal growth restriction, oligohydramnios, or classic abnormal placental histology. That is why surveillance is limited. Not useless, but limited. The proposed mechanisms fit that pattern. One mechanism is fetal arrhythmia. High bile acids may affect the fetal myocardium and conduction physiology. If the event is rhythm-related, a normal test yesterday may not protect tomorrow. A second mechanism is placental vasospasm, or vascular dysfunction. The Israeli paper mentions vasospasm of placental blood vessels due to elevated bile acids. A vascular event can be abrupt, not slowly progressive. A third signal is fetal cardiac dysfunction. The Israeli paper notes preliminary data linking bile acid levels with fetal cardiac dysfunction. That supports the idea that bile acids are not passive markers. They may be active fetal toxins. A fourth pathway is meconium and intrapartum fetal heart rate abnormalities. ICP is associated with meconium-stained fluid and fetal heart rate decelerations during labor. Again, this points to fetal stress that is not simply explained by a small placenta. Now let us bring in the most important evidence paper. Ovadia 2019 asked a question that clinicians had struggled with for years. Is there a bile acid level above which fetal risk truly changes? This was not a small case series. It included aggregate data and individual participant data, with more than 5,000 ICP cases in the individual participant data analysis. The key finding was that in singleton pregnancies, stillbirth was associated with maximum total bile acid concentration, not ALT. The numbers matter.
For bile acids below 40 micromoles per liter, stillbirth prevalence was about 0.13%. For bile acids 40 to 99, it was about 0.28%. For bile acids 100 or higher, it was about 3.44%. That is the shape of the risk. Not a smooth, gentle slope that makes every elevation equivalent. A major change at 100. Ovadia also showed that ALT was not a good stillbirth predictor. This is a high-yield clinical distinction. ALT can be dramatic and emotionally compelling because we see it on routine chemistry. But for the fetus, peak total bile acids carry the risk story. Say it simply. ALT tells you the maternal liver is irritated. Bile acids tell you the fetus is exposed. Now, there is an important nuance. Bile acids between 40 and 99 are not meaningless. They are associated with more adverse outcomes in the broader literature, and they influence delivery timing. The Israeli paper calls disease above 40 severe. Ovadia showed increasing spontaneous preterm birth with higher categories, and meconium and neonatal unit admission were more common in ICP overall. But for stillbirth, the strongest threshold is 100. This distinction helps prevent two opposite errors. The first error is panic. A patient with bile acids of 28 at 32 weeks has ICP, but she is not in the same risk category as a patient with bile acids of 120. The second error is complacency. A patient who reaches 105 is no longer just an itchy patient with abnormal labs. She has crossed into the high-risk bile acid category. Now, why do we use peak bile acids? Because fetal exposure is not erased by a later lower value. Treatment can reduce bile acids and improve labs. Sampling conditions vary. Bile acids can change rapidly with gestation. The highest measured value tells you that the pregnancy has demonstrated capacity for that level of exposure. Ovadia's interpretation was that women should be managed according to peak bile acid concentration, irrespective of ursodeoxycholic acid treatment, provided repeat testing is done. This is crucial. If ursodiol lowers the number, that is good for symptoms and biochemistry, but it does not prove that the stillbirth risk has been eliminated. Now, let's connect this to fetal surveillance. We do surveillance because the fetus is at risk, because clinical practice supports structured high-risk care, and because some abnormalities may be detected. But we should not teach residents that fetal surveillance is the mechanism that makes ICP safe. SMFN recommends starting surveillance when the gestational age is one at which an abnormal result would lead to delivery, or at diagnosis if diagnosis occurs later. This is a practical and intellectually honest rule. Do not start testing so early that you would not act on the result. Do not let normal testing override a delivery plan that is driven by bile acid risk. Now, let us summarize the pathophysiology as one chain. Pregnancy increases hormonal cholestatic pressure. A susceptible liver has impaired bile acid handling. Bile acids accumulate in maternal blood. The mother itches. The fetus is exposed. At high levels, especially 100 micromoles per liter or more, the stillbirth risk changes. The suspected fetal mechanism is sudden, involving rhythm, cardiac function, or placental vasospasm, not slow classic placental insufficiency. Therefore, surveillance is imperfect, and delivery timing becomes central. That is the whole intellectual architecture of ICP. Final synthesis. First, ICP is a bile acid transport disease exposed by pregnancy physiology. Second, the maternal symptom and the fetal risk marker are not identical. Itch matters, but peak bile acids guide fetal risk. Third, ICP fetal death may be sudden, which explains why normal NST or BPP results cannot fully reassure us. Fourth, Ovadia 2019 makes 100 micromoles per liter the key stillbirth risk threshold in singleton pregnancies. And the memory hook is this. The itch brings her in. The bile acids tell you how worried to be. Delivery ends the exposure. End of episode 3.